This is Dr. Charles Parker, and you're listening to Core Brain Journal. It's a place where I connect both fresh discoveries and interesting different perspectives from advanced mind science with the realities of real people and everyday life down on Main Street. Well, welcome once again, folks. Dr. Charles Parker here at Core Brain Journal, and we have a very profound guest with us today. He's been all over the universe in terms of women's health, estrogen issues, menopause, and his name is Dr. Seibel. I got to get it right, Seibel. And Dr. Seibel, welcome. We're really pleased to have you on board here.
Well, thank you, Dr. Parker. Thank you for asking me. It's a real pleasure and a privilege to join you.
So I'm going to do an intro, and what we're going to do is talk about his background, which is enormous, to say the least. And then he's going to tell us about his book and how he got to be where he is and what he thinks should be done about some of the very interesting topics regarding menopause, estrogen dominance, so on. So I'll read it to you. He's an international health expert and leading authority on women's wellness and menopause. When his wife had her ovaries removed to prevent cancer and was thrown into early menopause, her doctors weren't sure if estrogen was safe or she should take it at all. He had to find out the truth, and he set out to do so. As a result, Dr. Maish spent years researching estrogen and menopause and is passionate about helping women around the world get the information they need to, so to speak, figure it out so they don't have to, so to speak, tough it out themselves alone. His latest book, The Estrogen Window, which will be linked in the footnotes, uncovers the window of opportunity to begin estrogen to lower the risk of disease and optimize relief of symptoms. And I'm really looking forward to hearing about that because I think you're going to bring a different perspective to what I've learned. And so we're going to find out more about his book, The Estrogen Window, in a moment. Let me just say a couple of more things before we talk to him directly. Listen to his achievements, my friends. And I'm actually limiting it. I've got about half of them here, but I picked some of the highlights. 2014's, he presented to the Gates Foundation on Grand Challenges Explorations. He's the past editor-in-chief of the medical journal Sexuality, Reproduction, and Menopause. He is a professor at the University of Massachusetts Medical School, 2004 to present, and he's recently moved back to Harvard. He's the director of the Complicated Menopausal Program at the University of Massachusetts Medical School, 2004 to 2011, teaching at Harvard Medical School now. He's the author and editor of, get this, 15 books, over 200 scientific articles. He's on the advisory board of Dr. Oz's Health Corps initiative to fight childhood obesity. And he's a nationally known guest speaker, keynote speaker, health and wellness advocate. I just love talking to him before we even warmed up to get on the program. So welcome, Dr.
Seibel.
I'm going to say it right. Seibel like Bible. I'll get it. So
well, let me just say my mother thanks you for that introduction. So I thank you. So
thank you. So tell us a little bit about yourself personally and how you got where you are. How did you go down this path? We heard about your wife. Are you an OBGYN person? Are you an internist?
I am an OBGYN. I actually started my career down the Gulf Coast of Texas and from a little town in Texas called Texas City, Texas. Grew up there and had the privilege to go to medical school at the University of Texas undergraduate and then to medical school at the University of Texas, where I had a mentor there, Dr. Al LeBlanc, who's now passed on, but he was just such a wonderful role model that I knew I wanted to grow up and be like him. Mm-hmm. So I went into OB and GYN and then did my residency at the university at Emory University in Atlanta, mm-hmm. which was a wonderful experience, and then found myself a displaced Southerner in New England at Harvard Medical School, did my fellowship there, and I had the privilege to do some of the very first in vitro fertilizations in the country, and subsequently even helped the gorillas get pregnant at the zoo. and was written up in People magazine for helping gorillas. So, and when I was calling in a prescription for one of the gorillas, the woman on the phone said, "Does this gorilla have insurance?" And he didn't know it was a gorilla. She just said, "I just called it in for Mandy." And she said, "Well, does Mandy have insurance?" I said, "Yes, HMO Zoo." But anyway, and then continued my efforts in the infertility arena for quite some time. And then, as my introduction, you mentioned, when in 2002 a study came out incorrectly stating that hormones, particularly estrogen and estrogen-related compounds, were responsible for breast cancer, heart disease, and dementia, among other things. And I say incorrectly stated that estrogen and hormones suddenly went from being something that everyone got to something that you needed an informed consent to get from the medical community, and it was challenging to get it. And then shortly after that, they discovered a gene called the BRCA, or the breast cancer gene, which increases the risk of both breast cancer and ovarian cancer. And my wife, who had lost many of the women in her family before the age of 50 to ovarian cancer, got tested, and it was positive. And so she found herself in early menopause at a time when estrogen had gone from something to give to everyone to something that they were reluctant to give. And as you stated earlier, I changed careers. I say I used to do sperm to term, and then I decided to go womb to tomb, and ultimately made a decision to put my efforts into menopause, because I really believe that the studies that I read cursorily at that time and subsequently in great detail multiple times, along with everything that's come out since, prove those studies wrong. And I really needed to figure this out so that she and the patients that I had acquired wouldn't have to tough it out, as you said. And I feel very strongly about that.
Well, I'm so appreciative of you bringing this up, because it's going to be a learning experience for me talking to you right here. There's no question about it, because I've read all the studies that talk about, not all the studies, I've read a number of books, probably, I would say somewhere between 10 and 15 books that get into the whole thing of estrogen dominance. And it sounds like you have a different take on it. And so I'm so much looking forward to it, because one of my things that I do in every woman evaluation is look for the signs of what I have perceived to this moment as estrogen dominance. So would you please address the concept of estrogen dominance symptomatically in the first place?
Well, estrogen dominance is an important topic, but I wonder if I could digress for one moment to explain why these studies got it so wrong and why women should understand this. Because as I've been going around the country speaking on my book tour for the Estrogen Window and addressed hundreds of women around the country, I usually start out by asking three questions. I ask first, how many of you think estrogen is unsafe and something that can cause cancer? And a number of the women will raise their hands. And then I'll ask, how many of you think that estrogen is perfectly safe and something that's a reasonable treatment for menopausal symptoms? And a few other women will raise their hands. And then I say, well, how many of you are actually a bit confused and uncertain if you don't know what to think about hormone therapy? And everybody raises their hands. And so what happens is the basis of this study happened in 2002, and it was something called the WHI, or the Women's Health Initiative. And the Women's Health Initiative was a study that was requested because hormones, in particular estrogen, as objective studies, just observational studies, they're called, because you don't have a comparison to a control group, those women seem to be having a less risk of heart disease. And so the powers that be wanted to have this study, but there were so many women on estrogen at the time, they couldn't find enough women to be in the actual study itself. And so while the study compared women in the first one taking estrogen plus a synthetic progesterone called Provera, so it was Premarin, the estrogen, plus Provera, or Prem-Pro, they were taking that medicine and compared to a group taking a placebo. And while the women were 50 to 79 years old in the study, the women who got the Prempro were 75% 60 to 79 years old, and the women who got the placebo were 75% 50 to 59 years old. So you're comparing 60 to 79-year-old women to 50 to 59-year-old women. Now, in addition, it was a well-woman study, so the women were supposed to be healthy. It turned out that the women who got the Prempro were 60 to 79 years old predominantly, and they were many smokers, many hypertensives, and many women with diabetes. And they were being compared again to women who were largely 50 to 59 who were none of the above. So when you compare those two groups of women, who do you think is going to have the more problems? And it's going to be the older women who are biologically older. They're going to have the conditions that happen to women as they age. And they're also going to do it more than the women who are younger and in good health. And that's what happened. And it turns out, to cut to the chase, that and what my book is about is that when you take the same data, which was done in 2013, the same exact data, and you match it by age. In other words, you take the women who got the Prempro and compare them to women who got the control, suddenly things change. And it turns out that the women who take the hormones actually live longer than the women who don't get hormones, even when it's the same data grouping. It turns out they have less risk of diabetes, less risk of heart disease. They have less risk of diabetes, less risk of osteoporosis. Now, there is a very slight risk of breast cancer, and I want to clarify how much. It's less than the risk of breast cancer for a woman who drinks 1 to 2 glasses of wine a week, and about the same as a woman who has dense breasts or who has her first child after age 35. So it's minimal, but if it's adjusted for age, and that's what this window is about. It's about starting hormones close to the time of menopause or within 10 years of menopause. And that's very important. And one other point, there was another group of women who had had a hysterectomy and therefore only required to take estrogen. You only need to add progesterone to estrogen if you have a uterus to protect the uterine lining. Otherwise, you only need estrogen alone. The women who had taken estrogen only, when they were compared to women who took the control group, the placebo, they in fact had 23% lower risk of breast cancer, 32% lower risk of heart disease, and a significant diminished risk of dementia. So we're talking about major differences of benefit for women who take estrogen only, and only modest increased risk, minimal, for women who take the combined contraceptive. If it started in the estrogen window, which is within 10 years of menopause, and the earlier the better, or between the ages of 50 to 59 if menopause occurs on average at 51, which is when it typically occurs.
That is so interesting. What a wonderful summary on a lot of research. And I was pleased that you put in the dementia thing, because I've read a lot about Alzheimer's being related in some respects to this issue. And because I was biased in the other direction based on what I was reading, people would say, you shouldn't be even doing estrogen to prevent Alzheimer's, because that's another contributory factor to the possibility of cancer.
Well, here's the issue. If you wait until you're 69 to start it, or 65 to start it, you can increase the risk of dementia. You can increase the risk of urinary frequency. But if you started early, the reverse is true. As a matter of fact, we have to be mindful that between 5 and 10% of women go into menopause before age 46. In other words, 45 or younger. That's 5 to 10% of women. At 6,000 women a day going into menopause, that's between 300 and 600 women a day going into menopause before age 40. At 45 or younger, 1 in 100 goes into menopause before age 40, and the symptoms can start up to a decade before that. So you could be a woman in your 30s, even your early 30s, having symptoms of fogginess. You could be having palpitations. You could be having a urinary frequency. You could be having vaginal dryness, any of these things. And you could be going to 4 or 5 different doctors wondering what the heck is going on. And it could be symptoms, could be of early menopause. And in that set of conditions, if you fail to take estrogen until at least the time of menopause, the risk of dementia actually can go up as high as 70% for women who go into early menopause. Heart disease goes up substantially. Suicidal ideation goes up substantially. It's a terrible, terrible toll for women who suffer, and needlessly, because they're the very ones who should be getting hormones just to maintain the status quo of their bodies and prevent this early aging.
That is so interesting. We're going to, this is so exciting. I want to ask you some other questions, but I just want our listeners to know right at this moment that what's happened is Dr. Seibel has also given us a giveaway, 1-year subscription to the magazine, the Hot Years Menopause magazine. These details are going to be in the magazine, so make sure when you go over to the show notes, if you're just listening to this on your iPhone, go over to the show notes and sign in there, because then you would have an opportunity to, and we'll leave it open for 2 weeks from the time this is published, to win that possible subscription. That's very, very, very interesting. Thank you so much for supplying that.
Absolutely. And I want as many women as can to do that, to go to mymenopausemag.com. Go there, go and get to that link, click on it and get this subscription and get all this information, because it's free and it's interesting interviews, there's recipes, there's summaries of the latest medical information, exercise tips, the things that you need to age with vibrancy. And that's what you'll be given. So take advantage of it.
Thank you so much. Now, let me ask you this question, because this is very helpful to me. And I think that what's happening, what I, as a professional talking with people about this on a regular basis, it encourages me to think more deeply about what the signs of premenopause are, and to really know them better. I mean, I've been looking at these symptoms as more as a, do you have, the simple way, hot flashes? Do you have, had you had a problem with dysmenorrhea or menorrhagia, cramping or heavy flow? Have your periods been regular or irregular? Did you have a period of things that would be signs of PCOS in your career, in your during your menstrual cycles? So I'm asking kind of the hard signs, but you're really bringing up some soft signs that really happen to be psychological, interestingly enough.
Oh, I think that the psychological components, the mental health area for women who are in transition is totally underappreciated, because it sneaks up on women quietly. Because just like when you go through puberty and your hormones are out of whack and you're transitioning at a time of imbalance, when you're going from being a little girl to being a young woman, and your hormones are trying and struggling to get paired with each other, but are fumbling with each other and going in and out of balance, there you are struggling. Your brain is affected, your body is changing, your mood is off, everything is different. Your skin, your complexion, your growing breasts, your hips are getting curvy, all this body change and mental change. Well, when you get through your reproductive years and you start to have that same kind of imbalance, but interestingly backwards, because hormonally the same things are happening. You're going from a higher level to a low level at this time, instead of from a low level to a high level. So what happens is, once again, you can start at your head and work down your body. You start to have cloudy thinking, irritability, anxiety is very, very common. Sad thoughts are often common. If you have a tendency, if you're a woman who had postpartum depression, if you're a woman who has had clinical depression in the past, if you've had severe PMS in the past, you may be having a tendency to clinical depression, meaning your depression and sadness is significant and it lasts 2 weeks or longer. You can start to have changes in your eyes. They can start to get dry. Your mouth can get dry. You can start to have differences in your sleep. You're more susceptible to sleep apnea and being awakened. You might be the person who's now suddenly snoring more, gasping in the night. Your breasts may start to feel different. Your heart starts to have palpitations. You start to get dryness in the vaginal tissues. Your sensitivity in your bladder may start to happen. You start to notice crow's feet in your eyes and the corners of your eyes because the collagen under your skin is starting to be leached out as estrogen levels start to go down. And similarly, the scaffolding of your skeleton, your bones are starting to lose the same kinds of tissue. The calcium is coming out, and it's important to get a bone density around this time to see where you are, so you can see where you are a year from then or 2 years from then and see that you're not developing osteoporosis or thinning of the bones. Because remember, if you're a healthy 50-year-old woman, your chance of dying from a complication of osteoporosis is exactly the same as your risk of dying from breast cancer. And everybody's got a pink ribbon, but nobody's got that white bone ribbon around, and you've got to be mindful of all of this. So all of these things are happening, can affect your libido. Your mojo can be a no-show, as some of the women say. You can start to realize a muffin around kind of, your waist starts to go, because estrogen is responsible for the distribution of fat, where it stays and moves it and mobilizes to the belly. So all of this is happening. It's a total body experience, and estrogen is a salve for the woman in many ways, and a balm, B-A-L-M, not a B-O-M-B, for the brain. It is, you're a brain expert, and estrogen is responsible for maintaining the memory better. It makes the neurons in the brain, the synapses go faster. In other words, your nerves in your brain fire faster. Your balance stays better. Your core stays stronger. All your reflexes are quicker. All the things that you take for granted on a routine basis are affected. Serotonin, which makes you happy, goes up as a result of estrogen, so that it improves mood, and the lack of that is tied into some of the sadness that happens. There's a whole host and cascade of things happening all at once.
Mesh, that is so helpful. I'm going to mark that specifically, that whole series of things you've talked about, and I'm sure they're in your book. I mean, this is going to be a very interesting point. I've got to get the book and read it myself and get on top of this, because what you're talking about is so absolutely relevant for anyone interested in mind science. This is Core Brain Journal. Yes, we are here because people do have difficulties, emotional difficulties, with menstrual irregularities and perimenopause and that whole situation. Let me ask you this question. Now, you don't know me, but I'm absolutely not a cookie cutter kind of guy. So I'm going to ask you a question that's going to sound like a cookie cutter question, but it really is not a cookie cutter question.
Okay.
It's a kind of general interest. Where do you go? What do you do? So upon measuring this, do you have some specific recommendations? Of course, without doing an examination, whatever, but what do you think needs, what are some of your favorite intervention systems from an estrogen point of view that have the least amount of difficulty and the most possible benefit for our listeners?
You're talking about what means of offering estrogen to women?
Yeah, medication specifically, if you don't mind.
Okay, no, I don't mind at all. I'm going to preface my comments by saying that whether or not you take estrogen, it's very important to take care of the sum of you and not just some of you. In other words, you've got to be mindful of your body, but also your mind and your spirit. And in this transition, where things no longer seem the same, where your footing is not as firm as it once seemed to be, Your lifestyle habits matter a lot. The sleep you have, the stress reduction that you need, the nutrition that you get, the exercises that your body requires in order to stay optimum, all of that is part of it. It's all part of, actually, I have an online program called Menopause Breakthrough, but I cover all this stuff. And the lifestyle is very important, and in Thriving Beyond, also maintaining your mindset and your sense of purpose and your mindfulness and some access to spirituality. All of these things as well are very important. Having said that, because whether or not you take hormones, I encourage every woman to look at herself for the sum of her and not some of her. But I do think that early on, what happens is the most important things that have to happen, I think, is to try and look at the person symptomatically. As a woman is in perimenopause, she's actually not estrogen deficient. She's actually mostly progesterone deficient, and I'll explain why. If you think about reproduction from a fertility point of view, let's talk about the menstrual cycle as a 4-week project every month. The first 2 weeks of the cycle, estrogen levels go from very low to, for the body, relatively high levels. They go from about 20 picograms or 30 picograms in the blood to somewhere around 200 picograms. They increase about tenfold. Now, all of that is coming from the cells around, or most of it is coming from the cells that surround the egg. One of those eggs is going to develop and ovulate and release the follicle is actually the cyst that contains the egg, and the cells around the follicle are making this. And then as it releases the egg, progesterone is made in the second half of the cycle. And so estrogen will stay at the same level, and progesterone rises from 0 and goes up to its height for the next 2 weeks. So what happens is, in menopause, there's many eggs, but as the eggs are now the ones that are the oldest in the woman's body, they don't respond with the same briskness that they once did. So 1 will start to develop, and then 2 will start to develop, and 10 will start to develop, but none of them necessarily ever reach maturity. That's why the cycles get longer. But the stimulus for that, the FSH, the follicle stimulating hormone from the pituitary gland, keeps trying to talk to the ovary louder and louder, and it makes the ovary stimulate more and more, trying to get an egg out and get levels of estrogen up to prepare the uterine lining. But the ovary can't listen too well. It gets like hard of hearing. So what happens is estrogen is going up and up and up, but because there's no egg release or infrequent egg release, the cells never convert to ones that make progesterone, and there's no progesterone. So the second half of the cycle, women need progesterone, not estrogen at all. Over time, in the year to 3 or so before menopause actually occurs, in that window, both hormones will be lower. And at that time, many of the simplest things to do are to give someone a very low dose oral contraceptive. That's commonly done. There are many ways to treat this. That's not a requirement, but it's the simplest, because it's just like when girls have PMS, sometimes they'll get put on an oral contraceptive because it just levels out imbalanced hormones. And similarly, there's some similarity to PMS in the way the hormones are imbalanced around perimenopause. So the stability of oral contraceptive is fine. But of course, as long as you're on that, you're not going to know if you're in menopause or not, because you're basically getting, in a way, hormone replacement. Ultimately, then, if a woman has only a uterus, and she wants to go on hormones, she has to have, as I mentioned earlier, estrogen plus progesterone. She has to protect the uterine lining. If she doesn't have a uterus, then she only needs estrogen. And generally, the main amount that people need, the major difference is between none and some. So I start women at the very lowest amount possible. And then it may have to be adjusted over, months or years, because things change.
Now, when you adjust it, how do you adjust it? Do you do it by blood, or do you do it by symptoms, or how does that take place?
Well, you can, there's a lot of ways to do it. If you wanted to do it the lowest tech, you can look actually at the cells in the vagina, and the cells of the vagina will change under low estrogen. The ones that have low estrogen will have more of a bigger nucleus and a small cytoplasm, and the ones that have estrogen exposure will have a small nucleus and a big cytoplasm. But the in the world of hormone testing, the world that I live in is not a big believer in the saliva testing. I know it's very popular among many people, and I'm not going to say bad things about it, but I will just say if you go to the literature that I read and to the meetings that I attend, most people would say it's less precise and it's much more dependent. It depends on if you smoked, how hydrated you are, a variety of things, and people are not big believers in that as the best route. They'll go with blood, which is a much more precise and much more consistently reproducible approach to it. So that would be my way to do it. I don't think you have to do it like all the time. If I were starting a woman who I had, tested and she had no problems and everything were fine, and I started her at a very low dose, and in a couple of months she was still having symptoms. Maybe they were not as dramatic as they were earlier. I would just bump it up from the lowest to the next lowest, and incrementally, and then perhaps at a yearly level, check blood levels. And if she has a uterus, you check the lining of the uterus to be careful that there's no buildup of those tissues.
Very interesting. That's different than what I've heard, because I've been hanging out with the functional medicine guys, and I've been looking at the psychological, psychiatric implications of it. But this is a different, important message, and it's very useful and very helpful. So then, when a person, what's your pattern after a period of time? When do you terminate estrogen replacement therapy, or do you? How does that work out?
Well, I tell women when I get them started on hormone replacement, if they're candidates and they want it, I tell them that I consider hormone replacement a 5-year renewable option. And I say that because two things change every 5 years. The person changes and the data changes. And so I'm always reassessing. I like to see people annually to make sure that nothing has changed that's relevant to their immediate health that I need to know about that would make a big difference. But otherwise, it's certainly important to be seen to consider it as like a 5-year renewable option, because up until recently, women were getting hormones. The guidelines would say give women the lowest dose for the shortest period of time. And just recently, the North American Menopause Society has come out with a new position statement saying give women the appropriate dose for the appropriate amount of time. We have to remember that the biggest bugaboo symptom that mostly drives women to the doctor for care or for symptomatic treatment is hot flashes. And we now know that hot flashes actually continue in a not insignificant number of women beyond 10 years. And there'll be a subset of women, maybe 7% or maybe a little bit more, 7 to 10%, that are going to have hot flashes beyond 65 and even into their 70s. So it's not like they're not affected once they come off. A second area that's important to talk about is that women often don't have symptoms of vaginal dryness at the time of menopause, but if they don't go on estrogen, because it generally shows up about 2 to 3 years after menopause, many times women don't connect what's now called, used to be called vaginal atrophy, now it's called genitourinary syndrome of menopause. And what is now regarded as that syndrome generally shows up several years after menopause when the tissues have gotten narrower and shorter and drier. We have to remember that the vagina doesn't really make that much lubrication. It's really a sweat organ. And what happens as the tissues are thicker and you're younger and the blood vessels are more prevalent in the tissues and the interstitial tissues between the tissues, that when they get engorged, the actual fluid that comes out is like a sweat through the wall of the vagina. And as those tissues narrow and the blood flow gets less and less, then what happens is it dries up. And so, as one woman told me long ago, she said, when I was young, my face was clear and my vagina had wrinkles. And she said, now my face has wrinkles and my vagina is smooth. So she said, so things are different. And that smoothness takes away what's called corrugation. If you look at your socks when you put your feet in, you know that the elastic will stretch and let a foot go in, and then it narrows around your ankle. And then what happens in the vagina is it's also corrugated. The walls go in and out and are stretchable so that it accommodates to a tampon or to a partner, a male partner, but it also allows a baby to pass through. But in older age, when the tissue loses that elasticity, it becomes a rigid organ that can't expand, and that's where the pain comes in, because everything is traumatic and traumatizing. And so this is all very important to be mindful. And even if you can't take a oral estrogen, let's say you have breast cancer or some reason you can't take it, or just say you don't want it, you can still take local estrogen even if you have estrogen receptor positive breast cancer, according to the American College of Obstetricians and Gynecologists opinion piece that just came out a few months ago, because they know that if you take it in those situations, that it doesn't increase the risk of recurrence and it doesn't increase the risk of death. And that's very important for women to know, because most women are avoiding it and they're suffering greatly from pain. And this is true if you're a survivor or if you're an actively being treated for estrogen receptor positive breast cancer. You can talk to your doctor or healthcare provider about this, and you should, because it can make a difference in the quality of your life and the quality of your relationship.
That is so useful and so helpful. I mean, so many women are suffering with these kinds of problems and are lost. I mean, it's really great to have you on and talking about this so directly and so authoritatively, because it makes a difference in people's lives. I mean, it's just very, very interesting. We see this all the time because individuals are talking about everything: their sexual life, their hormone condition, breast, if they have breast cancer. And it's really important that we as physicians become more informed. But we're so happy that you're able to help the public become more informed through this dialogue here.
Well, intimacy is a very important part of relationships, and to be deprived of it or to be put through a harrowing experience when it's not necessary is truly regrettable.
Well, that is a really excellent summary. I'm looking at our time here, and I'm thinking about winding up a little bit, but I want to thank you, but I also want to take a moment to have you tell us again. You had a couple of things that got added on that I'm going to add on the show notes regarding where to get the magazine and the Menopause Breakthrough. Could you tell us a little bit about that, with your website there and then your other website, please?
Sure. Well, my main website is drmache.com, drmache.com. And there I can truthfully say the doctor is always in. And you can go to the website and you can get information. There's a lot of free information, and there are some things that are available if people want to take it further. In addition, I also, Menopause Breakthrough is a free webinar that I have that really takes women through a lot of what goes on in this window of their life. And it gives them an introduction to 5 steps that I think are very important for overcoming menopause and for really having a positive experience. And if they do want to take it further, then there is a course that I offer called Menopause Breakthrough Action Plan. And in that scenario, then women can go, and it's at menopausebreakthroughactionplan.com, but you can go through that, and that allows you to get all the information and be on calls with me where I can actually walk women through menopause on weekly calls and then answer questions. And that goes on for about 6 weeks.
Nation, you're such an easy guy to talk to. I mean, who wouldn't want to do that if they had a problem? I mean, run over there and get an authority like yourself and have the opportunity to speak definitively about these nuanced personal problems that really nobody wants to talk about. It's a great opportunity, and I thank you once again for coming on. Folks, for those of you who are listening, I'm going to have all these linked on the show notes at this particular episode. Right now, I think it's 080, but because sometimes we move things around with the programs, but I think it's going to be corebrainjournal.com/080. And Mesh, what I'll do is I'll tell you when we get this out so you know what's going on.
Okay, that's awesome.
So thank you so much for coming on board. This has been so interesting. You have such a great, interesting personality on top of it, and you're so articulate. It just comes right across, and it's clear. I mean, it's a lot more clear for me, and I really appreciate it on a personal level.
Well, thank you. You're a wonderful host, and I'm grateful to be included, and we'll do it again sometime if you like.
I'd like to do it again. Thank you so much. You have a great evening. Thanks for listening to Co-Brain Journal. We're working every day behind the scenes to bring you reports that connect research benches with those street trenches. Here we share the complexity of mind science because, as you know, details really do matter. One of the most pervasive, misunderstood challenges is how commonplace medications, like those written for ADHD, are used so regularly without clear guidelines. If you think you'd like more specifics, take a minute to download my 2-page PDF packed with video links and references on the absolute essentials of how to start ADHD medications. They're easily available at corebrainjournal.com/start. Thanks for listening. Do connect and stay tuned. Together we can make a difference.